Live from Boston, my name is Emilio Madrigal, and welcome to this edition of Pathcast. I'm joined today by Dr. Sanchita Roy from Houston, Texas. Dr. Roy is an associate professor of pathology at the University of Texas MD Anderson Cancer Center, and her new book, Molecular Diagnostics in Cytopathology, a practical handbook for the practicing pathologist, is hot off the press from Springer International Publishing. Today, Dr. Roy will cover an essential topic in her lecture titled Molecular Cytopathology, Opportunities, Limitation, and Pitfalls. As always, please feel free to enter your comments and questions in the Facebook and YouTube chat windows. So with that, I'll turn the microphone over to Dr. Roy.
Good morning. Well, it's morning for me. Hello to everybody who's joining from across the planet. Thank you for letting me do this podcast today. So thank you for that introduction. And as you can tell from the title, I will be talking about molecular diagnostics and cytopathology, the opportunities, limitations, and pitfalls. Okay, so as we all are aware that the role of cytopathology is evolving. No longer is it one that we use only for diagnosis, but we're using cytology tissue more and more for clinical molecular assays. The question is, why this evolving role and why cytology? The primary reason is when we're talking about advanced stage cancer patients, these patients are not they're not candidates for surgical resection. So most of the time these patients are diagnosed either on a small biopsy or by cytology, and therefore it's critical to be able to utilize these small specimens, including the cytology, for all the critical molecular testing that's going to guide management. So what is the role of cytology? We talked about the why. We're doing this for better patient care. Now the question is, how do we do it and what do we test? And for that, I do want to bring up, this is like a shout out for the book that we recently published from Springer. My co-editors, Paul Vanderland, John Stewart, and Gilda Conasantos. And this is a practical handbook mainly on different, it's organ-based, and it kind of walks you through the molecular diagnostics that are primarily used in cytology. And I do want to give a shout out to Anna, who gave us a really excellent review. So this book is currently available on Amazon. It's available through Springer. So what I'm going to do today is kind of give you a kind of overview of what we do discuss in more detail in the book. Okay, so when we talk about molecular diagnostics in cytology or in pathology in general, we're mainly talking about tests that utilize either nucleic acids, so DNA or RNA-based testing, or something that utilizes the protein. Most of these DNA RNA-based tests are either based off some kind of amplification technique like PCR, or we're using some kind of hybridization technique like FISH, where we design probes that will detect the DNA or RNA that's being targeted. Protein-based tests, the most commonly utilized ones are the immuno-based assays, so immunohistochemistry that we do, where we're trying to identify antibodies that are expressed, like the proteins that are expressed. So cytology, this is basically my summary slide. And what I wanted to lay out there up front is that cytology provides an excellent substrate for molecular testing. And when I say molecular testing, I'm talking about all kinds of assays, so the DNA and RNA-based testing that I mentioned, so mutation analysis, FISH, as well as immuno-based tests. However, what's important to remember is that cytology specimens are a little different. They utilize many different kinds of fixatives and stains. And so when most assays in the molecular lab are validated on formalin-fixed tissue, so most protocols are designed and optimized for FFPE, you do have to appropriately validate your cytology specimens. So for that, another important issue is that there are multiple factors that impact the tissue quality. And so since you're using many different types of pre-analytics in these cytology specimens, it's important to realize that different pre-analytics will impact the quality of the tissue and the downstream testing. So recognizing these factors are also important. And as the pathologists, we are the ones that are triaging the tissue and handling the tissue. So we actually play a really important role in improving the success of biomarker testing. So let's take a quick look at the cytology specimen. So when we say cytology, we're talking either about aspiration specimens, so your FNAs, or exfoliative. And the most commonly utilized specimen preparations for molecular are your direct smears, liquid-based cytology, and your FFPE blocks. I've included others in there because there are places that will utilize fresh cells or frozen, but the most commonly used ones are your smears, liquid-based, and cell blocks. So if you look at, there are pros and cons for using each of these specimen preparations. Cell blocks are the most commonly utilized substrate. They're easy to acquire, easy to validate because they behave similar to your histologic specimens, easy to get sections. So they're probably the most easily validated substrate and the most widely utilized in a molecular test. The problem with cell blocks is that there is no immediate assessment, right? So there is a lot of variation in cellularity. Even when an FNA procedure may have on-site assessment, you cannot always guarantee that you'll get a good cell block. So they frequently suffer from a lack of cellularity. The other issue with a cell block is that these are formalin fixed, and formalin fixation causes artifacts. So they're not the most ideal substrate for PCR-based testing. The other issue with getting cell block sections is that when you cut sections, our standard sections are 4 to 5 micron. And so you're not going to get the entire nuclei. You're cutting through the nuclei, so you will not get the entire nucleic acid content from that cell. On the other hand, when you utilize smears, the biggest advantage is that you can make an immediate assessment at the time of the procedure. So you can kind of guarantee that you're going to get adequate material. You don't have formalin fixation, so you get high quality nucleic acids, and you get entire cells, so you get the entire nucleic acid content from the nuclei. The downside with using smears is that you do have to validate independently for any test that you're going to do. It requires some kind of skill and technique to prepare the smears, which may not be always available. And then lastly, when you use a smear for testing, you're going to sacrifice that smear. So there may be medical legal issues in terms of your archival slides and what you retain on file. Liquid-based cytology is being increasingly used for not just diagnosis, but for molecular testing, because these are collected in a special media which has standardized processing. So you have good preservation of your nucleic acid. They're easy to use because you can transport these as room temperature. And again, like the smears, you're utilizing whole cells, so you get the entire nucleic acid content from the nuclei. Liquid-based cytology has the issue where you cannot assess upfront in terms of the presence of tumor or quantify the amount of tumor there. And also, because it's a different media, you will have to validate again independently from your FFPE samples. So as far as FNAs go for molecular testing, these are great procedures because they're minimally invasive. You can target really small lesions, and you actually get a very good sampling of the lesion. Unlike a core biopsy, which is unidirectional, FNAs tend to sample the lesion more broadly. However, the biggest advantage of using an FNA is the fact that you're able to do an on-site assessment. And being able to do that, you can not only ensure the adequacy of the specimen, but you can appropriately triage that specimen. The other advantage of an FNA is that just from the inherent nature of how the FNA procedure works, you do aspirate a higher proportion of tumor cells and not as much of the stromal tissue. So your tumor fraction in an FNA sample tends to be much higher than when you compare it to a core biopsy sample. FNA specimens are also not decalcified. So when you are looking at a metastatic lesion to a bone, this would be the sample that you would select for molecular testing because you're not treating that with any kind of harsh acid. The problem with FNA often may be because you're using a small needle, your sample volume might be small, and so it may end up being inadequate for testing. The other issue with it is that when you're using a non-cell block specimen preparation, these would require additional validation for molecular testing, and therefore they've been historically underutilized for any kind of molecular. Your exfoliative effusion specimens, similar to FNAs, minimally invasive. You do get a broad representation of the tumor because your effusion specimens are often metastatic tumors and are probably more representative of the current mutation profile of the tumor. Effusions are typically large volume, easily sampled, so you could do repeat sampling. The problem with effusions often is that they're admixed with a lot of non-tumor cells, and so may often end up with a low tumor fraction. And then similar to your FNAs, if you're using non-cell block preparations, you will require additional validation when you're doing molecular testing. Historically, exfoliative cytology specimens like GYN specimen, urine specimens have been used for HPV testing or FISH. And so we have been using these cytology exfoliative specimens for molecular for several decades now. So in 2013, the American Society of Cytopathology and the PAP Society of Cytopathology issued a joint position statement on the utilization of cytology specimens for molecular. And shown here are the common indications that they cited. So what I'd like to draw your attention to is like this was 2013, so this was several years back. And if you look at the list of things that they listed, HPV testing for cervical cytology, head and neck cancers, testing for indeterminate thyroid FNAs, lung adenocarcinomas, melanomas, FISH testing, and next generation sequencing, we're still utilizing all of these tests. We're just utilizing it more widely. And more labs are actually validating cytology specimens so they can run these tests. So what I'd like to do is kind of run through that list and show you some of the key examples of how we utilize molecular testing in cytology. So let's start by looking at HPV testing because HPV testing in cervical cytology has been around for quite a while. The most commonly performed HPV testing is from a liquid-based cytology. Most of our cervical cytology has moved to liquid-based preparations where we're collecting for the preparation of thin prep or a SurePath slide, and then we use the residual fluid for the liquid-based cytology to do the HPV testing. Shown here is a table that kind of shows you the timeline of how we've utilized HPV testing, either for reflex testing for ASCAs or HPV PAP co-testing or primary screening. And there are several commercially available tests, and they have been approved in, for the different indications. So what we have been doing for HPV and cervical cytology, you could likely take that and utilize it for HPV testing in other sites, for example, your head and neck carcinomas. So this is a guideline from the College of American Pathologists for HPV testing in head and neck cancers that came out in 2018. And if you look at statement number 7, where they talk about cytology specimens, they say in the note that there was no recommendation that was made for the specific testing methodology for HPV in the FNA samples. So a lot of different institutions have been utilizing the HPV testing that we do for cervical cytology and have been applying it for head and neck cancers too. They also mentioned that if P16 IHC is used, the individual lab should validate the criteria. For SearchPath, we use 70% positivity as a cutoff. However, for cytology, there has been no specific guideline set, and so it's up to the individual labs to sort of validate what is considered positive. And same for the in situ hybridization that can also be used in cytology specimens. So let's take a look at molecular testing in thyroid cytology. So again, there are multiple commercially available molecular tests that are being performed on thyroid cytology. The most commonly used scenario where we use molecular testing is for the indeterminate thyroid cytology, so your AUS plus category or suspicious categories, where the results of your molecular test may rule in or rule out the possibility of malignancy. And shown here are the most commonly utilized tests. Afirma testing, for example, is widely used as a rule out test, so its negative predictive value is really good. Thyroseq, also widely used, has gone through several versions, and I think the numbers shown here are from Thyroseq 2. However, they have recently launched the Thyroseq 3 version 3. And if you see here, most of these tests require you to do an additional pass, like a dedicated pass in a separate media that can be sent for testing. These are done in a centralized lab. The only test that will let you test from smears is the Rosetta, where they will scrape off. You can send them your archival smears, and they will scrape off from the smear to perform the tests. So a lot of institutions have published where they, similar to how we do HPV testing from our residual liquid-based cytology, they have utilized the residual liquid-based cytology from the thyroid FNAs to show that you can actually do molecular testing, including next-gen sequencing. So basically, these residual fluids are discarded after the diagnosis is made. So if we are able to repurpose those residual liquid-based cytology and provide the molecular information that will supplement our diagnosis, then that's a really great way of making sure that we are providing a more comprehensive diagnosis and helping with the patient management. More recently, we have actually shown that you can, like when we do your FNA and you spin down your needle rinse, you can actually take the supernatant, which is discarded, and extract DNA out of the supernatant, and it's substantial amounts of DNA that can be used for next-gen sequencing or any other PCR-based testing. So let's move on to looking at molecular and lung cytology. So around 2004, with the discovery of the EGFR mutations, there have been several publications that have shown that you can do these molecular tests from cytology specimens. When the testing was initially implemented, people were doing more single gene based testing, and they would either scrape off or cell lift from smears or cell blocks, and would do Sanger sequencing or pyrosequencing, and have shown that you can do these from not just from the cell block specimens, but from smears as well as liquid-based cytology specimens. Now, every lab utilizes different platforms for doing some of these tests, and as I mentioned, most of these tests were single gene based testing, so either Sanger sequencing for EGFR or pyrosequencing for KRAS. And it was kind of um, at some point, given the number of genes that we were going to be testing, that it was inevitable that we would require a multi-gene platform. And Sequenome was one such platform which was able to do multiple genes at the same time. Now, this is currently what the genetic landscape of lung non-small cell lung cancer looks like. So this is actually a table out of the molecular diagnostics book that I showed you from the lung chapter by Paul van der Laan. And it shows you the 3 different tiers of genes that need to be tested for lung cancer. So you have your must test genes, which is your EGFR, ALK, ROS1, and BRAF. And then you have a should test gene set, which is things that you should test if you're using an expanded panel, like if you're using next-gen sequencing and you have the capability of testing all of these. And then there's a whole list of different other genes that are kind of upcoming, emerging targets that may not be in the guidelines right now, but may show up at some point. So there is an increasing need to be able to test multiple genes at the same time, which is where next-gen sequencing comes in, because for the first time, we have an assay that has a really high clinical sensitivity, so it can do multiple genes at the same time, and it also has a high analytic sensitivity. And we'll talk about the sensitivity of the assay in a little bit. And as I mentioned, it's a single platform. You can run one assay, and you can test multiple different alterations from single nucleotide variations, insertion deletions, amplifications, gene rearrangements, all on the same platform. So again, with the advent of next-gen sequencing, multiple institutions have published showing that you can do next-gen sequencing on different kinds of cytology specimens, including smears, as well as liquid-based preparations. Of course, cell blocks were some of the earliest specimens that were shown to be suitable for next-gen sequencing. So what about FISH testing? And so again, FISH testing can be done in cytology. These tests are less dependent on the tumor percentage. Each assay has specific requirements of the number of cells that you need. The main thing is that you should be able to distinguish the tumor nuclei from the background cells. So cytology samples, including smears and liquid-based, have been utilized for FISH. They have entire nuclei, so they don't have the truncation artifacts that you see with FFPE sections. And our cytotechs who do our FISH testing actually prefer our air-dried smears because the cells are, the nuclei are larger, so it's easier for them to count signals in them. Here are some publications on cytology smears and liquid-based preparations that have done ALK FISH in lung cytology. So some of these predictive markers in lung carcinoma are also available as IHC assays. So the most common EGFR mutations, the L858R and the exon 19 deletion, have specific EGFR mutation-specific antibodies, and these have shown to be highly sensitive and specific in cytology specimens. Also, ALK and ROS1 have antibodies that can be utilized. These have shown really good correlation in small biopsies. There have been a few limited studies in cytology for ALK with good correlation. There aren't that many studies using the ROS1 antibody, but I'm sure with time we'll see more studies that have utilized the ROS1 antibody. You can't talk about IHC in lung without mentioning PD-L1. PD-L1 is now part of the NCCN guidelines for the required tests for non-small cell lung cancer. And again, when PD-L1 was first validated, it was not validated on cytology. However, several publications have made their way into the literature that have shown that you can do PD-L1 on cytology, and they show really good correlation with their histologic counterparts. Now, most of these studies have been done on cytology cell blocks. We did publish a study where we compared not just cell blocks, but also our FNA smears, and they showed really good correlation with surgical pathology. As I mentioned before, biomarker testing using IHC requires optimization and validation. And because cytology specimens utilize different kinds of fixatives, and there are different pre-analytic factors that come into play, it is really important to have a rigorous validation and protocol optimization, because your protocols that work for your FFPE specimens may not necessarily work for a non-formalin fixed cytology specimen. For example, there was a publication from Mayo in 2016 that showed that alcohol fixation can decrease the IHC accuracy, and there may be a loss or decrease in immunogenicity if you do not optimize your protocols. So the CAP actually has guidelines in terms of how to validate for IHC assays. This is currently being updated, so there will be an updated guideline for IHC validation, and it's important to make sure that your IHC assays are validated, so you can, especially because when you're reporting predictive and prognostic markers, these impact how the patient's going to be treated. So this is critical that we validate our assays. So let's move on to urinary tract cytology. So as I mentioned, like FISH testing for our urine specimens have been around for a while. Eurovision is the most commonly utilized assay. And if you look in the new Paris system, the most, they recommend using ancillary studies for your category, which is your atypical urothelial cells. So a Eurovision assay in conjunction with your cytology may help you with the management of these patients. So how about FISH testing in other sites? So Pancreatobiliary tract. Again, this is a publication from the Mayo Clinic, and it shows you the sensitivity and specificity of using just positive cytology or positive suspicious cytology versus using Eurovision FISH, and then using a FISH assay that they designed the probes specific. It's kind of similar to the Eurovision probes, but a little different, and it shows a better sensitivity than the Eurovision FISH assay. And this is how the Mayo Clinic kind of utilizes the cytology in conjunction with the FISH assay to decide how they would report the final diagnosis on this cytology specimen. So pancreatic cyst fluids have been increasingly used for molecular testing. This publication from University of Pittsburgh shows that next generation sequencing can be used in pancreatic cyst fluids, and it helps in accurately classifying these different cysts. And so, for example, if you have a VHL mutation from your cyst fluid, there is a very high chance that this is a serous cyst adenoma, versus if you pick up something like a GNAS mutation, it has a high chance of being an IPMN. So let's talk a little bit about the mutation assays in cytology specimens. So as we're aware, this is increasingly becoming standard of care for multiple tumor types. And cytology specimens are great in terms of mutation assays because there are a wide variety of different specimen preparations. And because there's a wide variety, there's also a lot of versatility in terms of the specimen preparations. So, for example, you have a bunch of different specimen preparations that are not formalin fixed. So you get really high quality nucleic acid. And as I mentioned before, like your cytology specimens are not decalcified, so they're really ideal for testing in bony lesions. So I told you they're excellent substrate, and here's the proof. This is a publication that came out of Boston that showed that kind of compared the quality matrix of next-gen sequencing in different cytologic preparations. And they compared smears and liquid-based cytology with cell blocks and core biopsies. And they showed that the smears and liquid-based preparations have better quality matrix than their FFPE counterparts. We did a study at MD Anderson, and we looked at the tumor fraction of FNA specimens in comparison to concurrent core biopsies. And shown here is the tumor fraction of your FNAs against the tumor fraction of your core biopsies. And if you can see, the tumor fraction tends to be higher in the FNA specimens. This is something I mentioned earlier. It's just the inherent nature of the FNA that tends to aspirate more tumor cells. And that kind of translates to what you see in your molecular assays. These, the FNA NGS assays tend to have higher mutation allelic frequencies, as you can see here. And they tend to have lower number of failed amplicons. They have better amplicon coverage than the core biopsies. So they tend to be, if you're using non-formalin fixed specimens, you tend to get better sequencing results when compared to your formalin fixed specimens. So again, coming back to what I mentioned, that there are these different factors that impact tissue quality and how the molecular testing will succeed. So starting from when the tissue is acquired, there's multiple different processes that play a role in how that tissue will be behave for some of these downstream assays. And we don't have a lot of control of anything that happens pre-acquisition, but as pathologists, we do handle the tissue. We're the guardians of the tissue. So we actually play a big role in ensuring that we get a good quality tissue for the molecular testing. And even though this is a stepwise process from specimen acquisition, processing, handling, the biomarker testing, and the interpretation of the test, all of these steps are kind of interrelated and play a role in impacting how you actually end up with the test interpretation. So what is step one? So step one is you need an adequate sample. Obviously, biomarker testing works best when you have an adequate sample. So how do you ensure that you get an adequate sample? So one would be to use an image-guided procedure, because if you know where your needle is, chances are you'll be in the lesion and you'll get an adequate specimen. The second thing is the technique, right? So we all have our favorite radiologist who gives us good samples every single time, versus there are radiologists when you see on the schedule and you know that you're going to get a suboptimal sample. So it's the operator's skill and expertise. It's the needle gauge that's being used. It's the number of passes that they do. And it doesn't necessarily mean that doing more passes will get you a better sample, because sometimes maybe after the third pass, all you're getting is blood and you're just diluting the sample that you're getting. So it's of critical importance that the person who's doing the procedure knows what the best way is to get a sample. And this may often be specific to the lesion type, where the tumor is located, and they will have to optimize and readjust so they can get you a better sample. And then the communication between the ordering clinician, like if they're going to require molecular testing, what they need, and the communication between the radiologist and the pathologist and the person processing that specimen is critical in ensuring that you get an adequate sample and it's triaged the appropriate way. What about ROSE? So rapid on-site evaluation, as I mentioned, can be done at the time of the FNA procedure, and it can ensure that you're collecting an adequate sample, as well as ensure that you're triaging the sample adequately. So if I have an FNA procedure and I see a lot of neutrophils, I will ask the radiologist to collect in a sterile medium, send it for micro. If I see a lot of lymphocytes and I'm worried about lymphoma, I will send that specimen for flow. However, if I see malignant cells, I will direct the radiologist in a way, because I know I need to collect adequate tissue, because we're going to need molecular testing. We're going to need a good block so I can do my IHC. So you collect according to how you want to process that specimen downstream. So if you're in a place where your molecular lab will only test from FFPE material, or you're sending it out to a reference lab that only takes FFPE material, you want to minimize the amount of material that you put on the smear. So you establish the diagnosis, and then you maximize the needle rinse for the cell block. However, if you're at a lab where you can test from your smears, that's the only specimen that you can ensure at the time of the procedure that you're collecting an adequate sample. So you prioritize material on the smears, make sure that you have enough that you can test for your mutation analysis, your FISH testing, and you minimize the amount of material for your cell block. So step 2 is optimizing the specimen processing. As I mentioned, there's a wide variety of specimen preparations. You have your smears, you have cell blocks, you have liquid-based cytology. We have a wide variety of collection media. People collect in RPMI, they collect in saline, they collect in Cytolite, they collect in formalin. There's different preservatives. There's a wide variety of fixatives. There's different kinds of stains, glass slides, mounting medium. So the variety of our specimen preparations is just mind-boggling, which also creates a problem downstream, because there are quantitative and qualitative differences in the nucleic acid and protein that you get, and they vary according to processing techniques. This was a really nice study that was published in Cancer Cytopath that kind of compared different types of specimen preparations. They looked at spray-fixed specimens versus air-dried. They looked at Cytolite versus ethanol, cyto-rich red. They looked at different mounting mediums. And what I'm trying to highlight is not really which one's better, but really the fact that there are differences depending on how you process that specimen. And at our institution, we also saw that, depending on the type of glass slide you use, our fully frosted glass slides tend to give 4 times less DNA than our non-frosted slides or our positively charged slides. When we tried to compare scraping versus cell lifting techniques, scraping typically gave us higher nucleic acid yields, irrespective of which glass slide type that we were using. And why is it important? Why are we talking about DNA yield? Because DNA yield often correlates with the success of your molecular test. So we did a study where we looked at the NGS success rates, and it's kind of intuitive, but we did see that when you have a higher DNA yield, you tend to have a higher NGS success. Okay, so step 3 is selecting the right specimen for the biomarker testing, and it's ideally selecting the best specimen. So you want to know what the adequacy criteria are. You want to know what the tissue extraction strategies are. You want to know what the molecular lab is going to reject and what they're going to accept and what kind of platform they're using, so you can select the appropriate material for testing. And so when you're doing a specimen adequacy assessment, there are 2 things to pay attention to. One is the overall cellularity, which is all the nucleated cells in a sample, because that's what's going to translate to the DNA yield from that sample. The second thing that you need to pay attention to is the tumor cellularity, which is the proportion of tumor cells you have relative to all the other non-tumor cells in the background, because this is what relates to the analytic sensitivity of the molecular test platform. And to highlight that, I just want to draw your attention to this figure. So let's say most tumors tend to be heterozygous, which means that they have one mutant allele and one wild type allele. So if you have a sample where you have 40% tumor cells, so here you have a sample, these are your tumor cells in blue. You have one mutant allele, one wild type allele, while all your normal cells have two wild type alleles. So in a 40% tumor sample, you only have 20% that are mutant alleles. Therefore, if you have a sample that only has 10% tumor cells, you only have 5% of the alleles that are mutant, which means that for a sample like this, you need to have a test that has a 5% sensitivity to be able to detect that that 5% mutant allele that you have in your sample. So shown here, this is an older table, and it lists some of the the PCR-based testing that we had, and it shows you the analytic sensitivity. So, for example, Sanger sequencing has an analytic sensitivity of 15-20%. So, for Sanger sequencing to actually work, you need to have a tumor sample that has at least 30% or 40% tumor. On the other hand, a more targeted assay like, say, pyrosequencing or real-time PCR, you have a really good analytic sensitivity. So you can use a much lower tumor fraction sample and have these tests work. So if you use a sample that has 10% tumor fraction, your Sanger sequencing will likely result in a false negative result. And this is a very important concept to realize, because as the gatekeepers of that tumor that is being sent for testing, you're going to need to know what the platform is and what the sensitivity of that platform is if you are going to send an adequate specimen for testing. So how do you modulate your specimen to fit the assay? So you can look at every specimen and it'll fall in one of four quadrants. So you have to look at it in terms of cellularity and the tumor fraction, right? So if you have a high cellularity and a high tumor fraction sample, those are usually never an issue, because you can send it for any testing, irrespective of the analytic sensitivity. You'll get a good DNA yield and it'll work for whatever molecular test you're sending. The low cellularity and low tumor fraction samples, again, not an issue, because these will not work. You will not get an adequate DNA yield. It doesn't have adequate tumor cells. So these are usually rejected up front. The samples that are in this quadrant, which are your low cellularity but high tumor fraction. So shown here is like a paucicellular smear. You have a few cells, but they're all tumor cells. So your tumor fraction is high, but the cellularity is low. Shown here is another sample, which is entirely necrotic. There's few groups of viable tumor cells. Again, cellularity is low, but the tumor fraction is high. Now, this would work as long as you're sending enough number of slides to make that DNA yield that's required for testing. The most interesting group here is this one, which you have a lot of cells. So cellularity is pretty high. So your DNA yield is not an issue. However, you have tumor cells, but they're admixed with a lot of benign cells. So your tumor fraction is low. And these are the samples that run a high risk of a false negative result. So the goal for these samples is to try and enrich the sample in a way so you can increase the tumor fraction and you can push it out of this quadrant either into this quadrant or that quadrant. And here's a higher magnification view. So here's the sample cell block section. There's tumor, but there's a lot of benign lymphocytes in the background. Now, a sample like this is very hard to enrich because you would have to meticulously dissect out these tumor cells, which would be very tedious and difficult to do. However, this is the spear corresponding to this cell block section. And as you can see, most of the smear tends to have these clusters of tumor cells with a lot of benign cells. But the area that we selected for testing was on the edge where there were more tumor cells and less number of contaminating lymphocytes. So yes, you're sacrificing the overall cellularity. So if you took the entire slide, you'd have more cells, you'd have a higher DNA yield. But what you're trying to do is enrich for the tumor, so you reduce the chances of a false negative result. So can you do tumor enrichment on smears? Yes, of course. Like for your cell blocks, you will circle your H&E slides and they will scrape off the unstained slides based off the H&E. For your smears, what we typically do is we'll circle areas on the smear that are of interest. And since the circles are made on the cover slip, those will disappear when you take the cover slip off. So we flip the slide over and we etch the back of that slide with a diamond tip pen. So when you take that cover slip off, you can still see the areas that have been selected. And then our molecular lab tech will scrape off the areas of interest from that slide directly. And then depending on how big those circles are, they'll either do a macro dissection where you don't need a microscope, you can just scrape off from the slide, or they have to do it under a dissecting microscope. So it's a manual micro dissection. And shown here is this really nice publication from Professor Troncone's group in Italy that kind of outlines how you can prepare your cytology samples for molecular testing. Okay, so in the last few minutes, I just wanted to show you, kind of highlight that even though it sounds kind of simple, assessing for tumor fraction is an art, and it's an imprecise art. So here's a H&E stained cell block section, right? It's from an EBUS lymph node specimen that has metastatic adenocarcinoma. So we can see at this magnification, there is tumor, but there's a lot of lymphocytes in the background. And in this area where you tend to see a little bit more tumor cells, if you look at higher magnification, even here, there's probably 40% or 30% tumor at best, because even though the tumor cells are big and they jump out at you when you're looking at it, for every tumor cell, there's like 2 or 3 lymphocytes that are admixed that will dilute the amount of tumor that you have. Now, this specimen was, there was a request for molecular testing on this one. And it actually came to our, we got a request twice on this specimen for 2 different sets of testing. And it was sent for testing by 2 different pathologists. The first pathologist circled the entire section, said there was 50% tumor. The second pathologist circled the entire section, said there was 20% tumor. Now, as I showed you, this was the highly selected area, which probably has 30% or 40% tumor at best. If you take the entire thing, that's nowhere close. It's probably much, much lower. So this is definitely not 50%. If you take the whole thing, it's probably not even 20%. So the first time it was sent for testing, these were the results. It came back negative for EGFR. The thing was, this was a patient who actually had a known EGFR mutation. And this was a lymph node that was positive. They were suspecting resistance. So when the results came out, the clinician contacted the pathologist and said, there's something wrong because this patient has a known EGFR mutation. So it got sent in for testing again. The thing was, this was run by Sanger sequencing. You see it in the methodology, it says PCR-based DNA sequencing. And I've told you, like, Sanger sequencing needs at least 30 or 40% tumor, otherwise you'll get a false negative result. So when it came back, it was rerun by NGS, and NGS has a much better sensitivity, and we were able to pick up the exon 19 deletion that the patient already had. But we also picked up a T790M mutation, which is the resistance mutation, and which is what they were clinically suspecting. So it is important to appropriately train your pathologists who are doing adequacy assessments, one, to reduce the variation in assessing these specimens, and also to ensure that you're sending an appropriate specimen for testing and you reduce the number of false negative results. So coming back to my summary, which I showed you before, is I wanted to emphasize that cytology specimens are an excellent substrate for molecular testing. There are pre-analytic factors that will impact the tissue quality and the success of your testing. And so recognizing these factors are important. And we as pathologists play a key role in triaging and handling these specimens. So we are the gatekeepers of these specimens, and we can improve the success of testing as long as we're aware of these factors. So why are cytology specimens still underutilized? The main thing is that there's a lack of standardization in terms of specimen collection and processing. I showed you that different labs use different fixatives and different preservatives, different collection media, different stains. So until we standardize our procedures, it is harder for molecular labs to accept our specimens because for all these pre-analytic variables, they will have to validate the different specimen preparations. So there is a reluctance of the molecular labs to validate these because there's a wide variety of specimen preparations and they would have to validate for a multitude of molecular testing. There is also the lack of awareness in the community. I mean, there are countless times when you're doing a procedure and the radiologist comes in and asks you, oh, I didn't know you could do that on an FNA. So there is a lack of awareness, and so it's up to us to kind of increase that awareness in the community. And this is in not just the pathology community, but also our clinicians, because when you look at the clinical trials, the way the clinical trials are written, they typically exclude the cytology specimens. Everything is, the protocols are written for FFPE tissue. And so the more the different molecular labs validate these specimens, the more these specimens will be accepted for clinical trials and other molecular tests. So that's important. And then lastly, there is an overall reluctance of cytopathologists also to sacrifice cytology specimens. So we have seen even in our institution when there is a choice between selecting the cell block sections versus the smears, the pathologist typically selects the cell block sections because you know you can get multiple sections and you're not sacrificing any of the archival smears, even though you probably know that the smears will end up getting you better nucleic acids. So there are measures that can be taken where you either scan in your slides to replace the slides that will be used. You can take pictures of the slides, or you can ensure that you have some diagnostic slides that you retain on files, and then you can sacrifice some of the smears for testing. So the molecular table is getting busier every day. You have surgeons and oncologists and pathologists, and now you have a lot of other people joining that table. So if we don't take a seat at that table, you will only see the limitations and pitfalls for cytology, which is what we're trying to take out of the picture and show everyone that molecular cytopathology is a gold mine of opportunity. And we need to better utilize our specimens so we can help in the clinical decision making. So that's all I have for today. And if there are questions and I don't get around to answering any questions, feel free to reach out to me at my email, or you can reach out to me through Twitter. I'm happy to answer any questions. Thank you.
Thank you very much, Dr. Roy, for that excellent overview of the application of molecular pathology to cytology specimens. You'll be happy to know that you had several hundred live viewers from around the globe, including places like Bolivia, Dominican Republic, Egypt, Ghana, Malaysia, the Philippines, Zambia, and that's just to name a few. Let me see here. I think I do have a few questions from one of our YouTube viewers, Sam Al-Badri. They ask, how would you handle a cytology specimen with borderline cellularity for molecular testing? And they also mentioned, thank you for the wonderful lecture.
Thank you, Sam. Yeah, so that kind of falls in one of those 4 quadrants that I showed you. If you have limited cellularity, so I hope I'm understanding your question correctly, that you mean an overall cellularity. So if you have limited overall cellularity, you're kind of limited in terms of what you can do. So if you have a limited overall cellularity on a cell block, what I would recommend is cutting enough number of sections. So maybe if you send 10 sections on a regular specimen, for low cellularity specimens, cut additional sections, maybe 20 sections. And so the goal is to get enough cells. One cell has about 7 picograms of DNA. So for a test that needs about 10 nanograms of DNA, which is like your NGS ion torrent usually uses like 10 nanograms of DNA, you need about like 1,600 cells. So, which is not really a lot of cells if you think about it. So as long as you can get enough number of sections, you're good. If you're using smears or liquid-based cytology and you don't have enough cells, then you're kind of limited. But again, if you look at smears, often if you have one area where there's like this three-dimensional cluster, we tend to underestimate the number of cells there are. So what we tend to do is if we have a limited cellularity sample that we're not quite sure if it's going to work, we are on the side of still sending it, because if they extract and they're able to get adequate DNA, they will run it. And we often put in a note for our molecular lab saying that it's a limited cellularity sample. And so they have optimized their protocols where they will tend to elute in a smaller volume. So instead of eluting in, say, 60 microliters of fluid, they will elute in 40 or maybe 30. And so you get a higher concentration of DNA in that sample.
Okay. So there's a question from one of our Facebook viewers, Sidra Jahangir. They ask, what would be or what is the best material to prepare or to make cell blocks from FNAs, and especially if you want to use it for molecular studies?
So I guess you're asking the best way to make a cell block?
I think so. That's
okay. So again, the jury's out on that. I mean, it will depend on who you're asking. So
well, what do you guys do at MD Anderson?
So we tend to spin down our cell pellet, and then we spin it down with a mix of formalin and ethanol, and then we take that pellet out, and then we wrap it in a tissue, like in a filter paper, and put it in a cassette, and we just fix it in formalin. The best yield we've had for making cell blocks is the colloid and bag technique, which tends to be a little labor intensive, but it's usually like if we have something where we see a little teeny tiny fragments in the rinse that we're worried will not survive the cell block preparation, we will use the colloid and bag. It takes a little bit more effort, but it usually ends up getting you a much better technique. There's a bunch of different publications where they've compared different ways of making cell blocks. And again, I think part of it is, what works best for you, given the volume you have, whether you can give that extra time and effort in investing in a little bit more labor-intensive cell block preparation method. Most places will use histogel or a thrombin method to make their cell blocks. But yes, there's a lot of variation, which is the other thing that I was trying to allude to, is that a lot of molecular labs will accept cell blocks because they're formalin fixed, but at the same time, I don't think they quite realize that all cell blocks are not built equal. They're not processed the same way. And there's also variation in how we process our cell blocks.
Okay. So would you say how much more often are you using or are you sacrificing FNA smears compared to using the cell blocks?
I'm sorry, could you repeat that?
So sacrificing tissue or sacrificing specimens like the FNA smears. How much more often are you doing that in comparison to using the cell block?
Oh, so there is like a kind of I didn't show you the data, but we had a publication in Cancer Cytopath where we actually show the variation that we have even among our pathologists. So we have pathologists who are biased towards defending the cell block,
Sure.
partly because of the fact that, you can cut sections from the cell block and you can retain all your smears.
Right.
And then we have pathologists who are biased the other way, where they feel that the smears are going to give you better material, so you still have diagnostic material on your block, so it's worth sacrificing the smears as
Yep.
long as you're retaining one or two good smears. So it depends on the person, it depends on the practice, it depends on the institution, because there are some institutions that will not let you sacrifice your smears. So I think if you look across the board at our institution, I would say it's split down the middle. There's probably half of us that are biased towards using the smears, and there's half of us that are biased towards using the cell block. But it ultimately boils down to a personal preference. If you ask me, I would much rather use the smears, because I know I look at both sides. I do the molecular as well as the cytology,
Sure.
and to me, I can see that you have much better sequencing quality from your smears. So if I were selecting a case and I have a good cell block and I have a good smear, I'll take that little bit of extra effort to decover slip that smear and send that for testing, versus cutting additional sections from the block and
Right.
having a less, like a little bit of, if there's a lot of cells, it's probably not an issue because you get a ton of DNA. But formalin does create formalin fixation artifacts, and from a sequencing standpoint, I'd much rather use the smear.
And when you decide to do that and use a smear, are you scanning those slides for archival purposes?
Only if there's no other material. So what we tend to do is, because we're a very rows-heavy institution, so pretty much all our F&A procedures get on-site assessments. And so our radiologists are used to making multiple smears from each pass, because there's always somebody assessing them up front. So we usually have a lot of smears, so we will try to retain diagnostic smears for our archival purpose, and then we'll sacrifice whatever we can spare. Now, if all the diagnostic material is on one slide, that's a problem. And we have done something in the past where we've kind of scraped off most of the slide and retained a little piece that we will recover slip for our archival purposes. But yeah, if it's the only slide that's available for testing, we will either scan it in or take pictures or make sure that we have something on the archives that establishes the diagnosis.
Right. Yeah, I suppose scanning some of these slides would also give you the opportunity to run image analysis on them and figure out, right, like the percentage of tumor that you're going to be
Right.
sending for sequencing.
Right.
So there are some advantages
Yes.
to scanning.
Absolutely. Absolutely.
All right. Well, that's wonderful. So it looks like that's all the questions that I have here from Facebook and YouTube. Again, thank you so much for taking the time to go over this very important topic, both covering molecular and cytology. And thanks again for everyone that joined today. If you can always stay up to date with all the upcoming lectures, all the upcoming Pathcast sessions by signing up for our newsletter on our website. That's pathologycast.com. And I'll just quickly mention that on March 26th, Dr. Rodriguez will continue his 11-part neuropath series with neuronal and glioneuronal tumors. That's the lecture. And on the 12th of April, Dr. Firth will join us from the University of Pennsylvania for the first part of her 2-part Learning to Love the Liver Logically. So with that, goodbye from Boston. Thank you.